30-year-old, 40-year-old is going to think they're too young to have heart disease. Plaque buildup, the fatty streaks and all that, plaque progression begins in kids as young as 10 years old. Eating junk, you're not exercising, you're vaping or smoking, or all these unhealthy habits that do take a toll on your heart. As they keep that going, then 5 years, 10 years time, they see us for things like coronary artery disease where they have, heart attack.
Patients coming in and saying, oh, I want this one test or I want this one medication and this will fix everything. And I tell them all the time, especially with weight loss or especially with cholesterol, if I had a pill I could give you that would make you lose weight or make your cholesterol go back to normal, I wouldn't be in this job. I'd be a billionaire somewhere.
We touched upon CAC scans. How often or frequently are you guys utilizing CAC scans in your regular practice, the coronary artery calcium scoring? Are you guys using this kind of for the borderline patients that, their cholesterol is kind of borderline and they have history of high blood pressure, whether or not to start this person on a cholesterol medication like statin? How are you guys tailoring that into your everyday cardiology practice, Dr. Kashraf?
Frequently, I will use it, both for calcium scoring and also, CT angiogram, which is kind of like injecting contrast dye and give more information in terms of the degree of narrowing in the arteries of the heart. The calcium scoring is a really, in my opinion, it's a really good test for especially intermediate risk patients. And, it has been shown that by giving some, data to the patients who, if they have plaque, that improves the adherence to treatment as well. So I do discuss it with the patient often in terms of, prevention. I'm sure Dr. Lee does it probably on all the patients. Yeah, it's definitely a good tool in addition to other information that we get to risk stratify the patient and treat them.
Very good. Dr. Lee?
Yeah, I completely agree. I'll be honest, I usually, because I'm a huge proponent of statins, I'll usually just go straight to a statin if I don't like their cholesterol. But yeah. I definitely am a fan of a CAC score, especially if a patient has come in with a CAC score. I'll use it to my advantage to say, okay, if this shows that you have some plaque, I recommend a statin. This shows that your CAC score is too high. We need to add an aspirin on top of that to try to keep the blockages from worsening. And especially Dr. Kashraf, and Dr. Bhagat, like you said, as a risk factor for someone, I think the ACC guidelines, their official stance is if you're an intermediate risk of ASCVD and you're indecisive about a statin, a CAC can push you one way or the other. But also, we have used it for patients whose symptoms and numbers don't really add up.
Yeah, how aggressively essentially you want to treat them for quote unquote CAD, coronary artery disease. And we all get those patients that their cholesterol is, let's say, LDL cholesterol is 190. And they should be on a cholesterol medication, but you cannot talk them into taking cholesterol medication because they'll say things like, hey, I've heard it causes diabetes. I heard it causes muscle cramps. I've heard it causes X, Y, and Z. So I find that in those kind of patients, the CAC scan can be helpful, that you send them for a CAC scan and it shows some cholesterol deposition, some calcification and things like that. That may be what's needed to just push them over the edge. Like, hey, look, you do have coronary calcification and your cholesterol is super high. Now you should be on a statin. So I have used CAC scanning in those kind of scenarios for some special patient populations as well. How are you guys utilizing GLP-1 analogs? So that's kind of the other new rage these days, right? Like GLP-1 analogs, whether it's something like Ozempic, Victoza, and these agents that previously they were niched to the diabetic population or obesity and things like that. But recent studies have shown a cardiovascular mortality benefits that these agents do prolong life from a heart standpoint. So how are you guys utilizing them now in the outpatient setting? So if you have a patient, let's say with diabetes, are you starting them as a default on GLP-1 analogs, or how are you tailoring that strategy, Dr. Kashraf?
Yeah, so, I think you mentioned something very important. This type of treatments for diabetes have a dual effect on them for diabetes, heart, and, even improving the longevity. They really revolutionized and helped a lot of patients. So what I see now in my current practice is that it's mostly the primary care doctors that really have been very active and start these treatments early on. So most of the patients that I'm thinking to start this medication, they've already been started.
Hmm.
There are some that I start myself or some that I recommend to their primary care. Access to care is a little bit still issue in terms of getting approval from insurance and the cost and financial burden, especially with patients with heart disease. A lot of newer medications are expensive. So that's certainly, and unfortunately, it's a barrier, but we think about it a lot and we use it.
Okay. Yeah. Dr. Lee?
Yeah, I wish I had your primary internist referrals, Dr. Kashif. That would make my life so much easier. I've and it's always great when I
Yeah.
see someone who's already started on a GLP-1 agonist who needs it, especially if they're diabetic, they're overweight to obese. But I have started my fair share too. And it really depends on the cardiologist. There are some cardiologists who say this is a primary internist space or an endocrinologist space. I'm not going to touch it, which is fine. Not everybody is comfortable with every medication. Personally, obviously making sure they have no contraindications. So thyroid
Mm.
or family history of thyroid cancer, men, one or two, or making sure they don't have any gallbladder disease, pancreatitis. Then I think it is very reasonable, especially if they are in the obese category. If they're morbidly obese, stage 3 at least, I will, in addition, ask if they want a bariatric surgery referral because bariatric surgery and weight loss has actually been shown to decrease cardiovascular risk factors or cardiovascular events. But I'm not hesitant to start someone on it, even if they don't have a diagnosis of diabetes. I don't know what everybody's insurance is as different as themselves. So I will try to push it through. And I think as more and more insurance companies are starting to approve GLP-1 agonists after a cardiovascular event. But if they have diabetes, if they've had a cardiovascular event, that makes our jobs easier.
Mm.
If
Right.
they haven't, then I would focus more on lifestyle. Obviously, heart healthy diet, adequate exercise, 10,000 steps a day, 150 minutes of moderate exercise a week, and try to see if we can get them to a uh, healthier weight and decrease their risk factors that way.
Yeah, right. So I think one piece of the puzzle is that we can definitely advocate for GLP-1 agonists, let's say something like Ozempic or Victoza or whatever, because a big study had favorable heart outcomes. But the other part is fighting with the insurance company, just
That's right.
because it may not have made to the latest guideline yet. And even though multiple studies do show a favorable benefit, doesn't mean that it's updated in the guidelines right away. So yeah, so it can be a little bit tricky in that standpoint. So this leads us to the next question, that we have all these fancy technologies and all these new medications and the fancy ways of doing things and all this investment in cardiology, but heart disease still remains the number one cause of death worldwide and in the US. Why do you guys think heart disease is still the number one cause of death in the US, despite all these major strides and advancements we've made in the last 20, 30 years? What would you say to that, Dr. Kashif?
Yeah, I'm not surprised. One is that it's aging population, right? So we treat the cancers and infections. So, population is older, so there are more risk factors for heart disease. So we see more heart disease. And then the other thing is that despite all the technologies, our efforts in terms of treating the, what we call cardiometabolic syndromes, that has been not very successful because it's not easy, because it depends on, a lot of social factors, lifestyle, diet, access to care, social disparities, all of these things. It's a much harder job. I think
Yeah,
that's a fact.
yeah. So it's an easier job to put in a nice stent in a closed heart artery, but it's much more difficult to get that person to exercise daily, eat a new
Absolutely.
diet that doesn't taste good, and
Yeah.
exercise daily. So yeah, I completely agree with you. What about you, Dr. Lee? What do you
Um,
think?
yeah, absolutely. You all hit the nail on the head. I think, especially with a Western diet, and especially in areas where walk. So like in New York City, everybody walks everywhere. In Manhattan anyway. Once you get to the outskirts, and depending on your socioeconomic status and depending on your genetics and your culture, especially if your culture is you have more prevalent high carb, high fat, high salt diet, then I think that has a effect on people's risk of cardiovascular disease. I remember at my previous institution, I would be talking with a lot of patients. This place had pulled from rural areas. And I would be counseling them almost the entire time on, okay, you can't just have a steak and mashed potatoes every single day. And then they would complain that I'm taking away all the things that taste good. Um,
Exactly. You're taking
yeah,
away their joys and their American lifestyle.
exactly. Yeah. So and then like Dr. Kashif said, an aging population, which is great. But as we found that as people age, more and more diseases are cropping up. And then so that combined with our culture here in the United States, it has caused our rates of heart disease to still be very high.
Right. Yeah, I agree with you there. So my take is that, heart disease, especially coronary artery disease, is primarily lifestyle driven. Yes, getting older is a significant risk factor, but so is not eating healthy, not exercising, sedentary lifestyle, poor sleeping habits, work-life stress, and all those kind of other factors. And those other things are probably often not as emphasized or communicated with the patients, whether it's from the primary care doctors or whether it's from us cardiologists. We're too busy putting the acute fire out, that is their active heart disease, and we're less so focused on guiding or teaching or preaching about those risk factors, such as, hey, are you getting at least 7 hours of sleep per night? Hey, are you exercising at least 3 days a week, aerobic exercise, and at least 2 days a week of resistance training? Are you managing your stress better? Are you eating healthy, whether it's a Mediterranean diet, DASH diet, whole food plant-based diet, whatever? So just because we're too occupied in treating kind of the, I think, acute issues, whether it's patient does have history of coronary artery disease, patient does have AFib, patient does have congestive heart failure, patient does have a defibrillator in place and you're fixing that or whatever, that less time is probably spent on prevention and, kind of those lifestyle changings that do really account for probably majority of, heart attacks or coronary artery disease. So I think that's probably one of the facets that's overlooked, and we should be paying more importance as physicians, and probably also from the policymakers and the insurance standpoint, that those interventions, unfortunately, are not as well incentivized, and there's not much reimbursement in prevention. There's all this incentives and reimbursement for putting this fancy stent or putting this fancy defibrillator in this patient, and there's high reimbursement for that. But to a physician like Dr. Lee, who's focusing on this patient not getting a heart attack and focusing on his weight loss and lifestyle changes and things like that, reimbursement for prevention, unfortunately, tends to be lacking behind compared to acute issues like fixing a heart attack acutely. So that's, I think, part of the reason that prevention is not quite there, at least in the US, and we're still having, a steep rise in the number of heart attacks, and heart disease remains the number one killer for us in the US. What heart healthy advice do you give your patients or follow yourselves? What would be kind of your top 3 things that you preach when you see people in the clinic? Dr. Kashif?
I think obviously diet, paying attention to calories, limiting carbs, limiting salt, balanced diet with healthy fats. Then we get to, physical activity. It depends on how much they can do. The more, the better. So having some regular physical activity or exercise. And then staying away from toxins, smoking, limiting alcohol. This is in line with our previous discussion, but I would say diet, lifestyle, physical activity.
What about you, Dr. Lee?
Those are my top 3 as well. Smoking or tobacco use, that's the easiest, so to speak, thing to get rid of. Granted, I know it's very addictive and it's difficult to stop, especially for a lot of people who have started. but it's having absolutely none of it. The simplest way to help decrease heart disease risk. Diet as well. So I counsel my patients focusing more on fruits, vegetables, whole grains, whole wheat bread, whole grain pasta, brown rice, whole wheat flour, oatmeal, and then
Yeah.
lean proteins like nuts or beans or soy, and then not having as much of red meat, high fat dairy, fried foods, oily foods, anything with a ton of sugar, refined carbs, anything with a ton of salt. One of my half jokes is that I tell them you can choose one of these things to have every other day because I don't want to take away all the fun, but I want you to be able to have fun for a longer period of time. And then physical activity, like we've mentioned. And then, like Dr. Kashev brings up a good point, it's based on how physical and how active a person can be physically. If they're not able to get out of the house, I tell them to just walk and stand while they're watching TV, pace around the room. You don't have to go out and run a marathon. You
Right.
can walk a couple blocks. Ideally, 10,000 steps a day, 150 minutes of moderate exercise a week, or 75 minutes of intense exercise a week. Any physical activity is better than none. Or I screen everybody in my clinic for sleep apnea.
Mhm.
And I have a lot of patients who say, "Oh, I don't wake up gasping for breath." And yes, I'm glad you don't. But I have patients who haven't had that, but snore a lot, feel tired during the day, and end up having sleep apnea. But getting that treated decreases risk of heart disease, decreases risk of AFib as
Exactly.
well. So decreases high blood pressure and improves lung function. So I think the top three, as Dr. Kashev mentioned, and then the other two, I also look at when I have patients who come into my clinic.
Yeah. Yeah.
Mm.
It's funny when patients will sometimes come to you and say heart disease runs in my family. And sometimes I'll jokingly say like, yeah, but not running also runs in your family, which is true, when you see a lot of these patients. And sometimes it's tough, to counsel them about exercise and, not being sedentary, but they often have 20 other issues like chronic low back pain, osteoarthritis
Mhm.
of their knees and things like that. So then it's difficult. So I do see
Mm.
the patient's, perspective too. How active can they be if they can barely walk? And a lot of our patients unfortunately tend to be kind of like that they're have a lot of hip or knee issues, and that really restricts mobility. As you guys know, heart disease is also the number one cause of death among cardiologists.
Mhm.
What do you guys do personally to minimize your risk of personally developing heart disease in the future? Are you guys doing all of these things like eating healthy, exercising regularly, or any other sort of tips or tricks you guys are doing personally to minimize you developing heart disease? Dr. Kashev?
I think it's the same concept: healthy diet, physical activity,
Hmm.
lifestyle, reducing stress, sleep, building behaviors in a way, one small step at a time, using stairs in the hospital, moving around if you're in a clinic, not sitting most of the time. I think those small steps that will add up is probably a way that we can help ourselves. Yeah.
Exactly. To echo your point, I think you're exactly right. So one thing that I do based on what you just said is I always take stairs now. So
Yeah.
the hospital that I work at, it has about 8 stories, but there's also like basement and stuff. So whether I'm going from, the bottom floor to the seventh floor, whatever, I'm always taking stairs. And that up and down, you're seeing patients and all these kind of things. So that really adds up. And it's not just like a small thing that, hey, you're taking stairs on the Monday, you're just taking elevators the rest of the week. It's just on an everyday basis, you're taking stairs up and down. So that really, these small changes really add up. So
Mhm.
that's what people often don't realize. And the other thing is, let's say if I'm seeing patients in the clinic, so now instead of just sitting down at a desk, which I'm kind of doing now, I am standing up. So I have like this stand up kind of
Mm.
makeshift desk, and I'm just standing and I'm typing or dictating patient notes there. And that I think also kind of helps in terms of not just sitting like a couch potato all day. What about you, Dr. Lee?
I agree. The physical activity is a huge thing. So my hospital is very big and the stairs are tucked away. So I can't say I do the stairs as much now as I used to when I was training when the hospital is only 7 floors. But one of the things I've loved going to I don't know if we can say brand names here.
Sure, go ahead.
All right, so Orange Theory has been amazing. It's
Mhm.
Yeah.
got I set aside time, I go, I do the workout that I usually used to love to do before. And we've all been through this as cardiologists, all the training and all the tests and all the studying and all the patient care that we have to do that we don't have time for ourselves. So it's kind of do as I say, not as I do model in medicine in the United States. But just I found that, okay, I'm going to pay for this membership, so I would feel bad if I don't use it, and it's beneficial for my health. It makes me feel better for not taking the stairs as much as I used to. And I know that the cost of a gym membership, it can be prohibitive. So I again tell my patients, yeah, just go for a walk. Go down the street and back.
Yeah.
And
And so many of these exercises can be
yeah.
done at home, right? Like I tell
Mhm,
them, like you don't need to go to a gym just to sit ups, push ups, or
mhm,
run around your block. These are small things and build up
Mm.
from there. Sorry, I didn't
exactly.
mean to interrupt you.
No, no,
But
no.
you,
I completely agree. It helps that I walk to work and back as opposed to take the bus, drive, and so
oh,
on.
perfect.
Yeah, but you hit the nail on the head. Just go out and move. You don't have to be doing wind sprints.
And we're seeing patients on a day to day basis tackling cardiology from different perspectives and different specialties. What would you say is the best thing you like about your particular specialty and also the most frustrating thing, Dr. Kashif?
A lot of things that I like about my specialty, that connection that you form with the patients,
Hmm.
you know, for example, after a procedure and you follow them longitudinally, I think that's very rewarding. And, when you see the patients feel better, it doesn't matter, either clinical treatment, just medications or procedure either. So frustrating, I think the opposite side of it, when the outcomes are not the best that you have predicted, the emotional toll that will take out of you. It's probably the
Okay.
most frustrating part.
Dr. Lee?
Yeah, I completely agree again. It's just seeing patients whom I've made a positive impact on, especially longitudinally. They come in sick, and then slowly but surely we work together, make sure they're on the right meds, make sure they're having a good lifestyle, whatever treatments they need. If they need that stent, if they need that pacemaker, if they need that certain medication, and seeing them improve and get better. Eventually, I only see them once a year as opposed to every month or so. That is very rewarding. On the opposite side, you have patients that you're just not able to help. But all of us who have been trained and conditioned to want to help the patient and see them get better, that can be frustrating when you're not able to get through. And I have to tell myself that I'm here to guide them, but it's their choice on what they want to do with that information.
Exactly. So we as healthcare professionals can only advocate and, counsel and recommend things to the patient. It's ultimately up to the person to decide whether or not they want to act upon those recommendations. And that's where I think sometimes the lapse in some people's or patients' judgment is that you tell them, hey, you need to be on X, Y, and Z medications, you need to make these lifestyle changes, but maybe in their head, things are not computing well, or they feel like they're bulletproof or whatever it may be. Then they see you maybe 3 months later, a year later, and they're 10 times sicker. So, and they're in the ICU or whatever. So that I get that frustrations oftentimes, with certain kind of people that they are just resistant to
Mm.
change. And the EP world, the best thing I like is being able to cure arrhythmias. The worst thing or the frustrating thing is not being able to cure arrhythmias. So some arrhythmias, some heart rhythm issues, like SVTs or atrial flutter, they have a high cure rate. They do their ablation procedure and 95% success rate, and you've essentially cured this person of this particular heart rhythm issue. Some other arrhythmias, like atrial fibrillation, like you guys know, it has a lower success rate and it can be a bit more stubborn to fix. And that's sometimes challenging or frustrating that you did your best for this atrial fibrillation ablation and the patient sees you 3 months later. Now they're back in AFib. And that can be frustrating. Then you have to talk about new medications or repeat AFib ablation procedure or other things. And I think for me, that's kind of the frustrating part from the electrical side of things. What would you say is the biggest misconception that people outside of your field may have about your field? Dr. Kashif?
It's a tough question. Um, I don't know if it's a misconception or it's the way that, the information evolves. And, let's say the information that we give to public about the best diet, these things change, the studies change. So
Hmm.
sometimes this will, the public trust is very important, but the studies will change. So one study says, drink this 2 glasses of wine. The other study says, don't drink any wine. you know so and especially, and also the diet, there are things that are evolving always. So I think that it's important that we explain the rationale for the recommendation and what we think is the right interpretation of the of let's say, for example, some sort of result that has been published in media, to clear any questions or anything that is in any type of distrust to that type of recommendations.
So you may be educating the patient, rightfully so, that, hey, this medication or this cardiac related advice is the best one based on X, Y, and Z study. But 2 years later, there may be 10 more studies that counter what you already told the patient. So cardiology, just like any other field, it's an evolving field. And, we as physicians need to A, stay on top of the latest research, and B, be able to communicate that effectively to the patients that, hey, what I told you 2 years ago, that's outdated now, or
Mhm.
this has shifted. What about you, Dr. Lee?
So I will say I've been lucky in that a lot of my patients who have come to see me, they understand that medicine changes as well. Although I know there are patients out there who have said, wait, I you told me to be on this. Why should I not be on it anymore?
Yeah.
And then I think that misconception of this is what someone else has told me to do based off of, like you said, media reports or
Mhm.
other providers who I know they're doing as good of a job as they can, but they're not in cardiology. The first impressions are hard to shake, right?
Mhm.
So you have patients who hear this information and then come in and want me to do something that I don't agree with or I don't think is appropriate. Thankfully, most of them are open minded. Some of
Yeah.
them want to hang on to that first idea. So that's always tough. And then you just try to work with the patient, say, hey, I don't think this is ideal. This is what I recommend, and try to find a middle ground that you're both comfortable with. The other thing I think that is a misconception is patients coming in and saying, oh, I want this one test or I want this one medication and this will
Mhm.
fix everything. And I tell them all the time, especially with weight loss or especially with cholesterol, if I had a pill I could give you that would make you lose weight or make your cholesterol go back to normal, I wouldn't be in this job. I'd be a billionaire somewhere. And
I tell them that pill is exercise daily.
that's a good one. I should use that. I should write a prescription that says work out,
Yeah.
go
Mhm.
for a walk. And we're humans. We're not magicians. We have all this knowledge. And Dr. Bhagat and Dr. Kashif, you all have skills that can intervene on patients and have immediate effect. But that doesn't mean they can go back to their old ways and start drinking a ton of caffeine or start drinking a ton of alcohol or start eating every cheeseburger. They still have to do the work themselves. It's not, okay, I'm giving you a free pass to do whatever you want.
Yeah. So that's what I often, have a frank discussion with the patients. Let's say for something like atrial fibrillation, that is, more than just an arrhythmia, atrial fibrillation, you'll have people that are obese, they drink quite a bit of alcohol, they have sleep apnea, they have a lot of other sort of conditions that can be triggers for AFib. So what I tell them is, yes, I'll do your ablation because you'll benefit from it, and I'll do the best ablation possible. Okay. But this is a team approach. I can only do the best ablation, but part of this is under your control as well. So from your standpoint, I need you to lose weight. I need you to be, tested for sleep apnea if they, meet the body habitus and things like that. And I need you to cut back or even stop alcohol intake because these are some triggers. These are some things that can make your AFib worse. And these factors are under your control. So I can do the best ablation possible, but if those other factors are not being adequately addressed, then your AFib is going to come back. I have a discussion with the patients that it's not just your ablation and you're cured of this AFib. This is a teamwork approach, and you also have to put in the effort, just like I will put in the effort. So yeah, so that is often a misconception that I would say people will have about certain arrhythmias or EP related topics. What would you guys say is the most common mistake that people make in their 30s or 50s? So the most common heart-related mistakes that younger patients that we see in their 30s or 50s may be making, Dr. Kashif?
Starting the prevention late, I think prevention should start even sooner than 20s. Not checking their cholesterol panel, not checking for diabetes, not exercising, not having a healthy diet. I would say that's the most important one.
Yeah, those are definitely the big things. Dr. Lee?
I agree. The diet is a big one. Getting to a primary internist late. I'm not necessarily saying they need a cardiologist, but making sure they're on top of their health and seeing someone every year, making sure they're vaccinated, making sure they have a healthy lifestyle, making sure that they're being screened for anything that's preventable. And then one thing that is becoming more and more of a pet peeve is seeing the vape products and how it seems cool to be vaping. It's not as bad as tobacco, but honestly, it can be. And I think that's a big mistake that I've found younger people making, is just these unhealthy habits, thinking they're invincible, or they think it's not as bad, they can do it.
Yeah, so a 30-year-old, 40-year-old is going to think that they're too young to have heart disease, unfortunately. But we know from the studies back in the day, the autopsy studies, that atherosclerosis, kind of the plaque buildup, the fatty streaks and all that, plaque progression, begins in kids as young as 10 years old. So I wouldn't say that a 30-year-old is going to be protected from heart disease, but unfortunately, when you're a 30-year-old, you think you're bulletproof. So you're eating junk, you're not exercising, you're vaping or smoking or doing all these kind of partying, all these unhealthy habits that do take a toll on your heart. And this may not be evident right away, but as they keep that going, then 5 years, 10 years time, they come see us for things like coronary artery disease, where they have, a heart attack, or they have heart failure, certain heart rhythm issues. And by that time, the damage has already sort of taken place. And again, you're back to fixing that acute problem, and you're sort of past the prevention point now, unfortunately. So
And depending on your family history or your genetics, or even if it's just an abnormality, I've had 30-year-olds who have needed stents or had heart attacks. And their cholesterol or their inflammatory markers are severely abnormal, or they just are unlucky. And just because you're 30, there's a higher likelihood that your coronaries will be okay right now, but that's not 100% the case.
Right. It's always surprising to see these 30-year-olds or 40-year-olds with CHF or coronary artery disease. I think the focus should be on prevention, but that unfortunately is not the case. What would you tell medical students or fellows or residents that are interested in your particular specialty? So whether it's general cardiology prevention or interventional structural, how would you sell your specialty to them? Dr. Kashif?
What I usually tell either the residents or the fellows is to keep an open eye and consider all the options and see what works best in terms of obviously their interests, their abilities, the lifestyle that they want to have, and how they see themselves doing in 10 years, 20 years, 30 years. Kind of a longer term. Any type of field, any subtype of cardiology has its own good things and challenging parts. So it just has to fit their interests and how they see themselves in the future.
Yeah, be okay taking Semicol and 2 a.m.
Like
when you're 40 years old, 50 years old, you have kids and family.
Right. That's true.
Exactly. Yeah. So that's that was one of the reasons I didn't go into interventional.
No such thing as an EP emergency.
Yeah, it's very rare. So that I know EP training is longer, but that was one of the factors that persuaded me towards EP. What about you, Dr. Lee?
I agree with Dr. Kashif, just keeping an open mind. Another piece of advice I got from one of my attendings is just continuing to read and watch and listen. And that way you'll continue to learn, you'll continue to grow. One of the things that I love about prevention is that even though it's important to take care of people's health, it is fairly low pressure. I'm not coming in on STEMI calls, even though honestly, when I was a fellow, I enjoyed STEMI calls. I enjoy a good procedure. Sometimes I miss doing the arterial sticks and putting in a sheath. and wiring up the artery. But
Yeah, you enjoy it as a fellow, but imagine coming at 3 in the morning. Kashyap will tell you it's probably not as fun.
that is true. Fair enough.
Yeah.
I had a safety net.
Yeah, exactly.
But I will say though, is in terms of keeping open mind, I was interested enough in intervention to consider going for it, but my current occupation fell into my lap, and I thought, it's kind of a 51-49 almost, or 60-40, but I thought this was something I should pursue and see how it goes, because I don't know if I'd have this opportunity ever again. So just trying to keep an open mind, trying to see, but also knowing what your preferences are, what makes you happy.
Yeah, exactly.
Honestly.
And what you want to do for the rest of your life, 20, 30 years of your medical career. What I tell people about EP is if you find things that are intellectually stimulating and you enjoy working with your hands, because EP is quite cerebral. You're analyzing multiple things and patterns and coming up with plan how to fix this arrhythmia or whatever it is. But you also enjoy the procedural aspect of it. Those are the key aspects of EP. And if you enjoy those things, then you'll thrive in EP. We'll land this ship with some rapid fire questions for you guys. So 5 questions. All right. We'll start with Dr. Kashyap. Which heart healthy habit do you wish you took more seriously?
Exercise, I would say.
Okay. Dr. Lee?
Diet. There's way too much good food in New York.
Yeah, I can imagine. For me, it's probably, I would say diet too. I have a sweet tooth, unfortunately. What's one heart-related advice that needs to go, that's outdated, right? Or you just don't agree with? Dr. Kashyap?
I would say all fats are bad for the body. Yeah, there's some fats that are healthy. So kind of something related to diet.
Sure. Dr. Lee?
That because your HDL is normal, we don't need to worry about your LDL.
Yeah, I do hear that too. It's kind of annoying. I was like, no, man, your LDL is like 190. Come on.
Yep, exactly.
One unhealthy food you cannot resist. Dr. Kashyap?
I think sugar is the hardest thing to resist for me. Anything that can be sweet can be very tempting for me.
Dr. Lee?
Pizza.
Pizza? Yeah,
Pizza.
New York's got some good pizza.
New York's got slice shop on every corner.
Yeah. For me, I would say it's like chocolate cake or chocolate cookies, chocolate ice cream, things like that. So sweet and chocolatey.
Yeah.
One celebrity that needs a cardiology consult ASAP. Dr. Kashyap?
Tough question. That's in general term. I don't think all the celebrities that may look fit are healthy. So, some of them would need cardiology consult.
What about you, Dr. Lee? Anyone that comes to mind in particular?
Donald Trump. Considering how great his health is.
Yeah, he just passed some tests with flying colors, right?
Yeah, exactly. Every test he passes with flying colors.
Yeah, you often see these influencers with 6-packs and whatever, but that doesn't mean on the inside that they're healthy and their arteries are fine.
Right.
Because you often hear about these bodybuilders that die of heart disease or renal failure, things like that. Just because you're fit on the outside doesn't necessarily mean you're fit on the inside. Last question. Favorite conference you attended and why? Dr. Kashyap?
I like TCT or New York Valve, that type of conferences. TCT is probably the one that I enjoy most.
And because it has the latest interventional updates, or what's the reason?
Yeah, so it has anything catheter-based treatments and also medical therapy, any type of advances, new trials, and also social networking. We see, our former colleagues, former fellows, friends, learn from each other. I would say, that conference is usually my first go-to conference.
And new toys to Dr. Kashyap.
New toys? Yeah. What about for you, Dr. Lee? Any good preventative cardiology conference or any other ones you like?
So, National Lipid Association, I think, is a good one. There's a lot of education, like Dr. Kashyap said, a lot of networking and catching up with colleagues. It's big enough that you learn and you have a lot of cutting edge research, but small enough that you get to know all the big players in the lipid world, and you get to learn from them, and you get to pick their brains about whatever interesting cases or even non-interesting cases, see what their practice strategies are.
In the EP world, for us, it's probably the HRS, the Heart Rhythm Society. The last one has probably been my favorite one, the one we had, early this year in 2025. Part of the reason is because there was a big emphasis on this pulse field ablation PFA. And the other part is, of course, you get to meet your colleagues, people you train with, your previous mentors, previous attendings, things like that. And also the last one was in San Diego, so that didn't hurt.